All right, let's dive into one of the absolute cornerstones of clinical diagnosis, the abdominal examination. But look, this isn't just about ticking boxes on a checklist. We're going to treat this like a detective story, where all the clues are right there, written on and inside the patient's body, just waiting for us to find them.
And this quote, it just nails it. A really thoughtful exam isn't some rigid procedure. It's a conversation. It's about you becoming a kind of artisan, using the most fundamental tools we have, our own senses, to really listen to the story the abdomen is trying to tell.
Okay, before we even think about touching the patient, you have to know the golden rule, IAPP. That's inspection, auscultation, percussion, and palpation. And that order, it's non-negotiable. Why? Well, think about it. If you start poking and tapping on the belly, that's percussion and palpation, you're going to stir things up inside and change the bowel sounds. So we always listen before we touch. That way we get a true, unaltered picture of what's going on.
So, with that critical sequence locked in our minds, the very first thing we do is set the stage. A great exam is built on a foundation of trust and comfort, and that starts way before you ever lay a hand on the patient.
Here's what that looks like in practice. You, the clinician, should be on the patient's right side. The patient needs to be lying flat, as relaxed as they can be, with their arms just resting at their sides. And check out the exposure here. You need to see everything from the xiphisternum, that little bony part at the bottom of the breastbone, all the way down to the pubic bone. This gives you a full, clear view for your investigation.
And this is a huge one, folks. Just explaining what you're doing, making sure the patient is warm and comfortable, that's not just being nice. A tense patient is going to clench their abdominal muscles, making it pretty much impossible to feel what's happening underneath. Building that trust from moment one is an absolutely vital clinical skill.
Okay, on to our first step, inspection. This is all about the visual sweep. You know, like a detective arriving at a crime scene. You're just taking it all in, looking for any clues at all, from the super obvious to the really subtle.
So how do you make sure you don't miss anything? Use a mental map, kind of like this 13-point checklist. This guides your eyes systematically across the whole abdomen, so you're actively looking at the overall shape, the skin, the belly button. You're even looking for things like hernias or pulsations.
For instance, you'd start with the general shape, the contour. Is it flat? Is it scaphoid, which means kind of sunken in? Or is it distended, like it's bulging out? Then you could ask the patient to lift their head up a bit. See that midline bulge? That suggests the divarication of the recti muscles, a separation that can be a clue about chronic pressure inside the abdomen.
And the visual scan keeps going. You're looking for more stories written on the skin. What's the deal with that old surgical scar? What could it tell you? Do those dilated veins, that classic caput medusa, point towards liver disease? Every single thing you see is another piece of the puzzle.
Okay, so we've used our eyes. Now it's time to use our ears. We're moving on to the A in IAPP, auscultation. We're literally tuning into the sounds of the body to figure out what's happening inside.
And this diagram shows you your key listening posts. For bowel sounds, a good place to start is usually the right lower quadrant. But you're also going to listen over the major arteries for brutes. That's a sort of whooshing sound that means turbulent blood flow. And over the liver and spleen, you listen for friction rubs, which kind of sound like creaky leather and can be a sign of inflammation.
So what exactly are we listening for? Well, normally, you should hear some gurgling every 5 to 10 seconds. But what if the sounds are hyperactive, maybe high-pitched and tinkling? That could be a sign of a blockage. On the flip side, if the sounds are totally absent, and you have to listen for a good couple of minutes to be sure, it might point to a paralytic ileus, where the bowel has just stopped moving.
We've looked and we've listened. Now we get to create a sound map of what's hiding underneath the surface with percussion. By tapping on the abdomen, we can get a really good idea of whether the structures below are filled with gas, fluid, or if they're solid.
And here's how you do it. You place one finger, that's called the pleximeter, firmly down on the abdomen. Then, with the tip of a finger on your other hand, the plexor, you strike it. The whole trick is in the wrist. It's got to be a sharp, quick, snappy flick to get a nice, clear sound that you can actually interpret. Now here's a really cool, almost elegant application of percussion, checking for ascites, which is fluid in the abdomen. It's a neat little procedure. First, you tap from the middle of the belly outwards until the sound changes from a resonant drum-like sound over gas to a dull thud. You mark that spot. Then you have the patient roll onto their side. Gravity does its thing and the fluid shifts. When you percuss again, that area of dullness will have moved. It's an amazing way to see fluid just by using sound.
And finally, we arrive at the most hands-on, the most intimate part of the exam, palpation.
This is our chance to actually feel for any tenderness, muscle guarding, or masses. And the key here is a touch that is both gentle and confident.
You always start with light palpation. We're just using the pulps of our fingers, gently molding to the abdominal wall. The goal here isn't to dig in deep. It's to assess the surface, feel the muscle tone, and, most importantly, find out if there are any tender spots before we go any deeper.
And listen, this might be the most important tip in this whole explainer. Watch the patient's face, not your hands. A tiny wince, a guarded look. That's often the very first and most honest sign of tenderness, and you'll see it long before the patient even says, ouch.
Once you've done your light pass, you can move on to deep palpation. This is for assessing the organs underneath and searching for any deeper masses. You'll often see this two-handed technique. It's great because one hand can provide the pressure while the other hand does the feeling. It gives you way more sensitivity and control.
Okay, so what if you suspect something pretty serious, like appendicitis? You might perform a special test for what's called rebound tenderness. You press down slowly and deeply, and then you let go, quickly. A sharp jolt of pain on the release is a classic sign that the peritoneum, the lining of the abdominal cavity, is inflamed.
Now, a massive word of caution here. Because this can really hurt, you always do this test last. You have to explain to the patient exactly what you're about to do, and you only perform it if you have a strong suspicion it's necessary. Remember, our first job is to do no harm. So, we've done all 4 steps. We've inspected, auscultated, percussed, and palpated. But the real art is in the synthesis. It's about weaving all those individual clues together. So imagine this. During inspection, you see a distended abdomen. Then, with auscultation, you hear those high-pitched, tinkling bowel sounds. Percussion is resonant, like a drum, all over, and palpation reveals general tenderness. Individually, they're just findings, but you put them all together, they're telling a powerful story that points straight towards a bowel obstruction. That's the magic, turning observations into a diagnosis.
If you want to really master this skill, it all boils down to these 3 things. Be systematic, always follow IAPP. Every single time. It builds muscle memory. Be gentle. A kind, confident touch gets you way more information. And be thorough. It's that meticulous attention to the small details that uncovers the biggest clues.
By mastering this systematic approach, you're not just going through the motions. You're turning a routine procedure into a powerful diagnostic conversation. You see, every abdomen has a story, a set of secrets it's ready to tell. The only real question is, are you ready to listen?